Order, order. Welcome to this one-off session of the Health and Social Care Select Committee on NHS Pilots. So let's begin by just some quick introductions. So very briefly, your name, what you do, and why you're here. Can I start with Jennifer, please?
Hello, I'm Dr. Jennifer Kilcoyne. I'm a Clinical Director at Mersey Care NHS Foundation Trust. I'm also the Director of the National Hopes Programme, and I also work for the World Health Organisation delivering quality rights training across Europe.
Welcome.
Thank you.
Good morning, I'm John James. I'm the Chief Executive Officer of the Sickle Cell Society UK, which is the national charity for sickle cell.
Good morning, my name is Professor Solomon Tesfaye. I'm Professor of Diabetes Medicine at the University of Sheffield, and I work at Sheffield Teaching Hospitals.
Lovely. Well, as you were warned, we're going to give you 4 or 5 minutes, if it's all right, and no more, just to outline these 3 pilots, what they were about, and anything else you want to say about them. I will be quite strict about the time, though, because we've got lots of questions for you, and we really need to get through them before we can then question the department. So please forgive me if I start to sort of look at you intently. Can we please start with John James? Thank you very much.
Thank you very much. So the Sickle Cell Emergency Bypass Unit pilots came about because the Sickle Cell Society produced a report in 2021 called No One's Listening. And it highlighted the real problems with investment and care provided for people living with sickle cell, particularly in accident and emergency departments, where there are guidelines but they were not met. So 30 minutes you should get your pain relief. The vast majority of trusts in the country didn't meet that at all and didn't really care about meeting it, if I'm perfectly honest. So that report, which was done by the Society and the All-Party Parliamentary Group for Sickle Cell and Thalassemia, went to the NHS England, and they said, we accept that there are real challenges and underinvestment in what is essentially the country's biggest genetic blood condition. So they decided to establish a sickle cell improvement programme, recognising that they needed to do something to improve the care for people with sickle cell. So they implemented a sickle cell improvement programme, and as part of that programme they decided to set up 7 bypass, ED bypass units, so emergency department bypass units. So the problem that it was trying to resolve was the fact that experience in accident and emergency was appalling. And that was what patients were saying, that's what health clinicians were saying. So that's what it was trying to solve by having these bypass units 24/7, which would allow those patients to be seen by experts in sickle cell. And the 7 pilots, there are 4 in London and 3 outside, Sheffield, Leeds and Manchester. The interim valuation has been completed. That was in October. And what does the interim evaluation say? It says this is good for patients because they're now getting their pain relief in about 15 minutes. It's good for those healthcare professionals who provide the service. In terms of the wider context of the NHS, it is saving them money. So I'm just going to give you a brief example of Lewisham, where I think the data up to November of last year, they're saving through reduced admissions and reduced lengths of stay when people are admitted, somewhere in the order of £800,000. It takes about £600,000 to deliver the service, so in net terms we're talking about £200,000 savings. So it's good all round for patients and the NHS and the healthcare professionals providing
you have a
the
specific
service.
issue that you're willing to...
Yes, the specific issue is though these pilots were for 2 years, And we're now in a situation, so we're now in February, there is no certainty about the funding of the pilots going forward. So we have a situation where these are working well, the interim evaluation confirms they're working well, and there is no clarity from NHS England about the future funding. Complicated further by the fact that integrated care boards and the NHS are in
disarray.
Are in turmoil with change.
Yeah.
And that complicates the matter. And I'll just give you one real example. Because
Last one.
The last example. So in October, we visited and talked to one of the new nurses who was delivering the service at one of these pilots. And of course, she's been appointed till March and is worried about the future because nobody can tell her whether the service is going to be continued. And I think that that is unacceptable for hard-working healthcare staff.
Thank you so much. And well done, you kept to time.
Thank you.
Perfect. Solomon Tesfaye. Thank you so much, by the way, for your slides. We've seen them and digested them. So over to you.
Thank you very much. Thank you for this opportunity. We are in the middle of a diabetes epidemic, described as the greatest health challenge of the 21st century. In the UK, 1 in 5 adults have either diabetes or prediabetes, and this figure is rising. Each year, the disease causes more than 48,000 strokes, 34,000 heart attacks, 155,000 cases of heart failure, and diabetes is also the commonest cause of kidney dialysis. Honourable Committee, among the doom and the gloom, our eye screening service shines brightly. 20 years ago, diabetes was the commonest cause of working-age blindness. However, since the establishment of a separate, high uptake, greater than 80%, community-based national eye screening program using digital cameras with early referrals for sight-threatening diabetic eye disease and early treatments, the UK is the only country in the world where diabetes is no longer the commonest cause of working-age blindness. Great success story. A robust screening service that doesn't rely on extremely busy GP practices reduces blindness and was a game changer. These contrasts with diabetes-related amputations that have been rising to an all-time high of 180 every week, most of which are preventable. Amputations are devastating physically and emotionally. Many patients do not receive annual foot screening and present with diabetic foot ulcers to massively expanded foot clinics. Unfortunately, 5-year survival after foot ulcer is only 50%. Worse than most cancers such as breast, prostate or colorectal cancers. The cost of the diabetic foot, over £1 billion a year, is more than the combined cost of 3 of the most common cancers. Sadly, most of this cost covers hospital expense of amputations and ulcer treatment, with only 10% dedicated for prevention. What a missed opportunity to prevent in a developed country such as ours. Honourable Committee, current GP-based screening is not fit for purpose. Because GP practices are often extremely busy, they have competing demands, the practice nurses are unable to have enough time to do this screening. Why is it failing? And the solution for this is neighbourhood-based one-stop screening service. We've conducted hospital and community feasibility study of combined eye, foot and kidney screening, including all 9 care health checks funded by Sheffield Teaching Hospitals, and published our results in a peer-reviewed journal. Eye drops are put in. These patients are coming to the eye screening service. While the eye drops are working, it takes about 20 minutes, and then patients are taken to a second room where they have all the screening process, including blood tests done, and they leave 35 minutes later. So one-stop shop. This was followed by then piloting these in 4 large general practice hubs in Sheffield, and these GP hubs for 9 months during 2021. And the flow was excellent. The uptake was the same as eye screening, over 85%. And patients loved it because it reduced 6 appointments to GP practices over a year. So this this is really, it has high uptake, it is very well received by patients, and it aligns with the NHS 10-year plan of moving care to the community.
Yep.
And so I think this is the perfect opportunity to introduce this one-stop shop to these neighbourhood hubs.
Thank you for that introduction. And Dr. Jennifer Kilcoyne, please.
Thank you. So the HOPES programme was a nationally commissioned clinical and human rights-based model specifically designed to end long-term segregation, or I'll call it long-term LTS, just for brevity, and to reduce restrictive practices for autistic people, people with a learning disability, and children and young people. Long-term segregation is one of the most restrictive and harmful practices in mental health. Many people are living in isolation for not weeks or days, but for months and years. And in fact, the average in our programme was 415 days in long-term segregation. People in long-term segregation are often in bare rooms with nothing but a waterproof mattress on the floor. Food may be passed through a hatch, access to fresh air, meaningful activity or family contact is often very restricted and sometimes absent. The evidence is absolutely clear that LTS causes psychological, physical and social harm. Families tell us it feels like watching their loved ones disappear. Staff describe moral injury, compassion fatigue and burnout and feeling stuck and hopeless in a system that just is trapping people. And following a series of national reviews, we were approached by NHS England to look at a fundamentally different approach, and because of our work at Mersey Care, they asked us to roll out the HOPES programme at scale across England. The national programme began in 2022 and we took referrals from May, and then the national funding concluded in March 2025. And since then, we've shifted to local ICB funding, and that's significantly affected the programme's reach. HOPES is a human rights-based and it's a co-produced model. It's delivered by highly specialist practitioners who are relentlessly positive and values-driven. Just to illustrate with a brief case example, we worked with an autistic 16-year-old boy. He'd been in hospital for a year with escalating distress and harm. By the time HOPES got involved, he'd been in long-term segregation for 5 months. He was severely underweight. He was having 3 nasogastric feeds under restraint by 5 agency staff each day. He had stopped walking. He had stopped speaking. He spent most of his day rocking in distress. And the HOPES practitioner worked with the team, providing training, practice leadership, and demonstrating a low-demand relational approach. Using our checklist, the Barriers to Change checklist, she was able to work with the staff team to develop 3 key intervention targets that focused on building trust, communication, and access to an outdoor space. Within weeks, he began to communicate, and one of the first things that he started to write first, was please make the people in the white suits, the agency staff, go away. As trust developed, he re-engaged and LTS was ended, and then 6 months later, he was discharged to the community and as we got back into education. And this is what the HOPES team does. It works with teams, with the person and also their family to try and remove the barriers that are keeping people stuck in long-term segregation. In terms of impact and outcomes, to date, the HOPES programme has supported 174 people in segregation across 77 hospitals. We've trained 4,000 staff. An independent evaluation from Manchester Metropolitan University showed, of 122 cases, showed that with 68% of the people that we worked with, LTS was ended. 1 in 3 of those people moved to the community. Meaningful activity went up by over 100%, access to fresh air over 80%, seclusion reduced by 1/3, physical restraint by over 20%. And the impact on staff was also very significant. There were reductions in burnout, reductions in secondary trauma. But the most powerful, evidence comes from the people and the families themselves. So a young man who hugged his nan for the first time in 4 years a daughter who was at home for Christmas after 8 years, calling it the best day of her life, and a young woman who left LTS and is now living her best life in the community. Just very quickly, return on investment. LTS is very expensive. The CQC estimate between £800 and £3,000 per day. Our independent return on investment that we commissioned showed a return of 12 to 1 for the HOPES programme. And just thinking of the earlier case example alone, the agency care commissioned, the costs were £3,393 per day for that deeply traumatising and harmful care. And that totals £1.2 million per year, and that figure alone would almost fund the entire national programme. So just to show that change is possible, it's possible at scale, profound outcomes can be delivered, the return on investment is significant, both ethically, clinically and financially. And I'm here today to discuss the end of the national funding, the move to ICBs, as other people have mentioned, has left us with a postcode lottery, in effect, in terms of access to this proven evidence-based approach.
Thank you, all three of you. Exemplary. Let's carry on as we started. Ben Coleman.
Thank you very much, Chair, and it's very good to see all of you. Mr. James, can I just start talking to you? And I should say, Chair, that I had the pleasure of visiting the Sickle Cell Emergency Department bypass unit at St Mary's Hospital recently. I was very impressed, and I talked to patients there. I was very impressed by what they told me about the support they were receiving and how it made their lives much easier. So just a statement of declaration of interest there. You explained the pilot very well. Can you just briefly, and we've always played briefly because we're also pushed for time, explain the steps that were taken to get the funding for the pilot initially?
The steps that thank you very much for the question. The steps that we took initially was to highlight to NHS England, the Department of Health, how bereft sickle cell was as the country's biggest genetic blood condition in terms of comparable funding to other red cell conditions. And the report, the No One's Listening report, was stark in its evidence, and that evidence came from patients, families and healthcare professionals, some of whom are in the audience today. And the evidence was just something that they couldn't dispute. So they said, we accept the argument and we will set up an improvement programme. We being NHS England. Said that.
Which bit of NHS England?
The Health Inequalities Department of NHS England.
And when they set up the programme, and obviously a lot of detail, did they, just out of interest, did they just tell you that there would be building evaluation in from the beginning?
Yes.
There was a plan for that?
Yes, there was a plan for evaluation from the very outset.
And why was it delayed? It's delayed because it's not finished yet.
Yeah, it's not finished yet, and it's not due to finish until Q4 of 2026, is what we've been told from NHS England. Why it was late was that for some of the 7 pilots, they didn't all start from the same starting position. So there were delays in some places in recruiting staff. There were some delays in logistics about the space in which the bypass unit would be located at the trust. So the delays for the evaluation was primarily linked to some of the logistical elements with those trusts.
Right. And were you told at the beginning that the pilot would continue until the evaluation had completed, or was that just an assumption, or was it explicit?
We were told that the evaluation would be an important part of continuation or otherwise of the pilots.
The decision making.
The decision.
You were told
making.
that explicitly?
It's very rare that you get anything explicit like that in writing from NHS England, but that was the impression that we got, and that's why we pressed for the interim evaluation results to be made available before the end of March of this year.
Yes, and I understand that. Do you think the interim evaluation results are sufficient for the department to take a decision on whether to continue, or ICB to take a decision on whether to continue and even extend the pilots?
I believe so, yes, because the evaluation, which is independent, so first of all it's independent from the National Institute of Health and Research, and the indications, as I said in my opening statement, is that it's good for patients, it is now meeting, those pilots are meeting the National Institute of Care Excellent guidance on giving pain relief within 30 minutes, and it's much better than 30 minutes. So if we have a situation that says this is good for patients, and the healthcare professionals think it's great in supporting patients, and there are wider benefits for the NHS in terms of efficiency and savings, that's reduced length of stay, reduced admissions, what else would you need?
You said that you're saving about, do you think overall it saves about 200 grand per pilot, so 1.4 million if you take the 7 pilots as being saved. But of course that's the pilot, well, part of the thing that we've been discussing as a committee is often the NHS which say, oh, we'll do a pilot because we've got money for 3 years for something, we can scrabble that together. But they don't necessarily think about the long-term financial sustainability of the pilot. If it's as successful as the pilots we're hearing today about have been, you'd expect the department to plan on the basis of taking the pilot forward to a permanent status afterwards. Do you think that sort of financial sustainability was sufficiently taken into account, was reflected, was thought about enough when they started the pilots?
I don't think it was taken into account, and I'll just pick up your word about planning. So I accept that NHS England said we need to do something because of where sickle cell sits in the scheme of all these other red cell conditions. But I don't think there was a plan beyond the pilot. If there was, we wouldn't be having this conversation now. So I don't think it was the sustainability and extension, because it's only 7 units across the country. I don't think that was fully taken into account by NHS England and the decision makers.
I'd ask the same question to Jennifer. Very interesting to hear and read about what you've achieved. Do you also think that the NHS thought about the funding, longer term funding from the beginning?
No, I think that so there was funding for a pilot, and my understanding originally was that if the pilot was successful, then it would be continued as a national programme, because obviously there was a national concern and national issues, and as we know. Pardon?
Forgive me for interrupting you. Was that your understanding? On what basis was that your understanding?
I think just because it was a 3-year pilot, and then it was in the Department of Health response to Baroness Hollin's report, for example, it mentions that they are looking at the outcomes of the Hopes pilot. So I suppose I've read into that if the pilot was successful, then people would continue to fund it. Now, however, sort of halfway through the programme, at the beginning of 2024, NHS England then came back and said there would not be any national funding in 2024. The March 2025 was when the programme was ending. Well, actually, it was ending in December 2025, but they extended it to March 2025 because they were no longer doing the national funding. And what they said is that would enable us to get ICBs on board. However, the difficulty is that many people had made their plans.
When you have punting everything down to ICBs, you inevitably end up, unless the ICBs are all required to do the same thing, one will do it and others won't, and you get this postcode lottery. So are there some conditions, and we're talking about diabetes, we're talking about sickle cell, and we're talking about the issues that you've been addressing, are there some issues where you absolutely just doesn't work if you leave it to ICBs? Did you say it on diabetes, Professor Tesfaye?
I would agree with that. I think you need a national certainty for diabetes. We need to build on the eye screening program, which has been absolutely successful. It has very high uptake. Why reinvent the wheel? Patients come for eye screening, and we do the screening at that point. So that's taken away then immediately from ICBs, because ICBs have to cater so many things. And we have something that works. We've got the space, we've got the manpower, it's cost neutral, and that's why we aligned ourselves with a very successful eye screening program.
So do you think that the NHS, last question, do you think the NHS supports piloting new initiatives more than actually thinking about their adoption or long-term rollout? Does it sort of, I'd even go as far as to say, do you have the feeling the NHS thinks, well, we've got a bit of money, we'll stick it into a pilot, and then we hope in 3 years' time, if the pilot's successful, we'll be able to find a bit more money, but we might not be able to? Do you think it's as chaotic as that, or is it more thought through?
I don't think it's more thought through. I think it's exactly as you say. I think I'm using sickle cell as an example.
Thank you. Jennifer, I'm going to just a very short response. Yeah.
I think yeah, we had a 3-year programme. I think people were committed to do something. There was a lot of issues in the press, but I think that there was not a lot of thought gone into how we would sustain it.
Thank you. And Professor Tesfaye?
I would agree with that. I think we need a national strategy. The move to the community provides absolutely the perfect opportunity to implement the one-stop shop.
Thank you, Jen Croft.
Thank you, Chair. And Jennifer, if I could sort of start with you. When you first undertook your programme, what support was there available nationally to roll it out?
So when we first undertook the programme, we had support from the national team in NHS England. We made connections with the regional leads in NHS England as well, and they were responsible in terms of helping us develop the KPIs and the things that were of concern to colleagues and to frontline teams out across the country.
Thank you. And sorry, I should have said at the beginning, and apologies, Chair.
Yes, sorry.
I meant to declare an interest. I chair the All-Party Parliamentary Group on Learning Disability, and thank you for my colleague here for reminding me about that. What kind of support do you wish would have been available? What would have been more helpful if you had it?
I think it's that sustainability in the future. So what happened is, we ran a very successful pilot. There was kind of query whether there was going to be further funding. It became clear in 2024 that there wasn't going to be further funding and we would need to go to ICBs. But there was no kind of plan about how we would do that. There was no kind of infrastructure. There was no kind of contact information. So by region, there was massive variation. Some of the regional leads invited us to programme boards. Some of them did not. Some of them, shared our information. Some of them did not. So what we've had is that, we're very grateful to the ones that, did an excellent job in coordinating it. But what we've had is this kind of really patchwork engagement. And, we had probably 500 meetings with ICB colleagues to try to kind of present the programme, present data from their systems, etc. And actually, quite often we go to a follow-up meeting and it'd be completely different people again, and then we're even not sure if the decision makers were kind of aware of the information we were presenting. So it was very, very difficult then to get that follow-on funding.
Is that taking away from time that you'd be spent making clinical interventions?
Yes, it is, yeah.
And have you found when you go to different regions, you said there's quite a lot of variation, do you find that there's any kind of sort of cultural differences in how to adopt a programme that is so unique and different and embodies such a different approach?
Yeah, so I think some regions the ICBs work together as partners and kind of shared the costs, shared everything together, could recognise the benefits of the programme. Whereas others, some regions said, we'll just develop our own team, which kind of negating the amount of kind of development work and the kind of the rigour of the approach. Some kind of, had lots of cultural issues about an independent team continuing and wanted to kind of embed it in their own system. And while that's the overall gain, what we want to do is to make sure that the model is delivered with integrity and the kind of the rigour that it's been developed with.
Would you say there's something in having highly specialised staff carrying out the programme that perhaps you might not be able to find at a sort of hyper-local, regional, local ICB level?
Yeah, I think that the highly specialised staff is really helpful because what it does is it supports the teams. It's the teams in the end that do the work, but they do reflective practice leadership. And we select people who have been kind of, lead clinicians and kind of have that real values-based, relentlessly positive approach that needs to happen. And with clinical credibility. So what we eventually want to do is spread the kind of culture wider and get that culture change around long-term segregation. But what we need at the moment is that independence, because what we found with other restrictive practice leads, for example, is that they get sucked into the system about how things are done around here.
Is it... Within an organisation, you need sort of an outside perspective to break that kind of almost cultural, sort of institutionalised way of doing things. And that's what helps provide it from a national...
Yes,
Yeah.
yes, absolutely.
So going forward, what would help? Would it be a continued national rollout of the programme, or even on a regional basis? What would work?
It would be better if it was in specialised commissionings nationally, so that because it is a national issue, but these are a small number of very high cost, very, both personally and financially people. So when you break it down to ICBs, that it's kind of 1 or 2 people per ICB or 3 people. And what we're finding now is that many of the areas that haven't commissioned are now approaching us with very distressing cases to say, can we spot purchase this? But actually we've lost our practitioners in that area, we've lost the capability, and you can't run a cultural change programme on that kind of piecemeal short-term funding.
You can't just be sort of parachuted in to solve a brief thing. And do you think that there's an issue around the type of people who are served by the HOPES programme, that there's almost, because it's such a low prevalence per ICB, but also perhaps it's people that aren't always at the forefront of commissioners and planners' imaginations?
Yeah, I think that's absolutely an issue. I think that some of the people that we're working with are the most traumatised people in mental health services. They're highly invisible. In fact, the CQC called their report where they reviewed LTS the out of sight report, because people are often locked away, and people are, particularly if they don't have families advocating for them, a kind of clinical complacency sets in, and there's not that motivation for change. And that's why myself and my colleague really developed the HOPES programme, because we really felt that things had to change.
Thank you. And just to clarify, I think one of the standout things for me on Baroness Hollin's report was that there is no therapeutic benefit to long-term segregation. And I just kind of wanted to make that clear to the committee as well. And the results you've had from HOPES, you've said, have been highly successful for patients, for professionals, and for the wider NHS.
Yeah, absolutely. Yeah, I think we would concur. There's no therapeutic benefit. It's harmful. It's traumatising. It often leads to, increased distress, self-harm, suicidality. That it's a very negative intervention. And what we've shown is that relational care, where you create understanding and communication, really works and has that measurable outcomes as you described.
It needs highly specialist service to do so.
Yeah.
Thank you very much.
Thank
I'll
you.
hand back to the Chair.
Hamilton.
Good morning. Before I start, I have to declare an interest. One, I've met and worked quite closely with John through the sickle cell stuff that I've done. I've worked in sickle cell, and I've also led the sickle cell voluntary service in Birmingham, chairing it. So I've got a lot of history in the area. So, and that's how my colleague got involved. But anyway, let's move straight on. Can I start with John, then I'll move straight over to yourself, Jennifer, if you don't mind. I am always sceptical about evaluation processes. And as you know from conversations we've had privately, there have been some real issues with these projects and many others, because they have been put there just to like a sticking plaster type thing. But there hasn't been any real evaluation. They've not costed it properly, and they've absolutely not looked at the effectiveness that you guys have talked about today. So my question to you is, did the ICBs really want to secure adoption? And if they did, what did you think they needed to do to ensure that adoption of these projects did happen? And I'll start with yourself, John, and then I'll move to yourself, Jennifer.
Thank you very much for the question. The first thing to clarify is that the 7 emergency department bypass units are funded centrally by NHS England, not the integrated care boards. And that's an important distinction to make.
For it to be funded by the integrated care boards, what was the evaluation process like for them to say, we are now going to take this on?
Well, I don't think that we have got to that position yet, because the national position over decades, and you'll know this from the West Midlands, is that different ICBs in the country, as Jennifer has said, take a very laissez-faire view about some specialised services, Sickle being one of them. So as far as I'm concerned, it has not got to a stage where ICBs are engaged in a conversation about how emergency department pilot units could be rolled out and funded by them. We have not got to that stage yet. The important thing for us as a charity was ensuring that the patient and family voice in that evaluation was strong and vibrant, alongside those of clinicians.
Thank you. And Jennifer?
So we were a national funded project. We had, as I said, quite a number of meetings with ICBs in relation to the evaluation. What we also presented at various boards in relation to that, and broke it down to the impact on their particular citizens in the ICBs, to show the impact in terms of cost, in terms of who we've worked with, who we got out of long-term segregation. I think that what the ICBs needed, personally, is some kind of national mandate to kind of engage in this programme. So, if, for example, reducing long-term segregation was in, the NIHR framework for providers, or had some national mandate around that, I think that they would engage more. But I think that what happens is there's lots of competing demands, and often the people at the meeting are either quite divorced from the frontline clinicians, so who are asking us for support and help and can see the benefits, or often, the people at the meetings, it's the decision maker in a finance board somewhere that is making the decision about whether to continue with hopes, and with competing priorities, the flux in the system. So, for example, in the Midlands, we had 11 ICBs that we were trying to work with to gain funding commissioning. And originally there were 7 people that were interested in funding the HOPES programme. When the changes to NHS England and the ICB announcement happened, then it dropped down to 4, and then eventually only one of those part funded some of the programme. So I think that it's also been compounded by the landscape, the commissioning landscape at the moment.
So my final question, then I'll hand back to the chair, because we're building, as they'd say. Do you feel that these projects were ever going to be rolled out? Jennifer?
Oh. I hope so. I do think that they came from a very good intention. I think that we thought that because we had such robust evaluation, we had an interim evaluation, then a full evaluation. I thought that they would be continued to be fairly compelling evidence. I think the difficulty is that ICBs are not working in partnership together, and it's such a fragmented system that it just has created so many barriers.
And John?
Without the sustainability of these pilots, we go backwards for the people who live with sickle cell, and that will increase health inequalities for that group, without a question. So from the beginning, I saw this as part of a journey to sustain and improve the care for these patients.
I'm going to leave it there, because you've put me at the end, so I'll...
Thank you very much.
Thank you.
Before I pass to Alex McIntyre, can I just ask you, Solomon Tesfaye, One Stop didn't ask for an evaluation. Is that correct?
No,
and why is that?
We did our own internal evaluation, but it didn't have an external independent evaluation.
Yeah, and what drove that decision?
Because of funding, really. I think to have an external evaluation, health economics and statistical analysis requires appropriate degree of funding. And so we struggled with that. And so we had an internal evaluation.
Okay, that's helpful to understand. Thank you. Alex McIntyre.
Thank you very much. Before I start, I should declare I'm an officer on the APPG for diabetes, and I had a fantastic visit up to Sheffield to see Solomon and his team and the work they're doing in Sheffield on diabetes. Some of the stats you shared at the start, Solomon, are pretty terrifying. I mean, we're on World Cancer Day today, and I think it would shock many people to know that diabetic foot disease has a worse survival rate than the average of all cancers. And as a type 2 diabetic myself, I know the pain of trying to find time to go to the GP on several occasions to have all of these different tests, and everybody goes for their eye screening because you're terrified of losing your eyesight, and my eyes are starting to deteriorate because of my diabetes. But as you say, the foot test is often not picked up on. And the one-stop shops that were piloted in Sheffield saw a massive uptake in that, didn't they?
Yes.
And can you also just explain briefly for the committee the difference between, so most people when they get their feet checked, I can't even get my words out, their feet checked at the GP, they have a filament test, don't they?
Yes.
But that picks up on diabetic foot disease at quite a late stage, doesn't it?
Yes.
And can you tell us a little bit about the work that you've been doing in Sheffield to pilot new technology that actually detects foot disease earlier?
Okay. Thank you very much, Alex. I think, as the committee will appreciate, foot disease and amputations are devastating, really. I mean, they're the most feared complications together with eye disease. And the methodology of using this monofilament, we stick them on the patient's feet and say, can you feel that? A lot of these patients may be cognitively impaired, and it picks up the disease when it is advanced. But because people can feel it, we give them a false sense of security. Actually, the neuropathy is progressing. So what we developed in Sheffield is a new point-of-care devices that were developed in Harvard Medical School. We test them because of our interest in neuropathy. So they detect early peripheral neuropathy. Using DPN check, we call it. It measures nerve conduction within 3 minutes, and pseudo scan. You put hands and feet, and again detects small nerve fiber damage very early. The one-stop shop is conducive to try new methodology. You can't adopt this in every GP practice. However, if you have hubs, expertise can be developed in these hubs. And so what you're doing is really, I think this one-stop approach is conducive to having this technology, targets prevention, enables digital stratification, and so that, if patients are perfectly normal, then they can come in 2 years' time. There's no need to follow people that have, but the ones with early changes need to be stratified so that they have early management, early treatment, so that everything is normalized. A patient said to me, Professor Tesfaye, we have MOT in this country for our cars, and we don't take the brake to one garage and you take the engine to another garage. Everything is done in one garage, and if the brakes are faulty, you can't drive it until it's roadworthy, it's fixed. Why is that not happening for me as a patient? I want not only to tell me there is something wrong, but that to be fixed. And at the moment, we're not doing that properly in primary care, which is extremely stretched, competing demands. And the people that lose out are people that are disadvantaged, people with mental health issues, people that have deprivation, economically, socially deprived. These are the ones that cannot attend 4-6 times appointments in a GP, in highly stretched GP practices. If we align this service to eye screening, eye drops put in, and we've shown this flows beautifully, and can be done by healthcare assistants. They're not expensive like practice nurses, and they can be trained to be really good at this because they will have a critical mass in GP hubs, which you don't get in individual GP practices. So this is really the perfect opportunity to introduce this one-stop shop in community hubs.
And given, the stats you shared about we're spending £1 billion a year as an NHS on diabetic foot disease, and the wider complications of diabetes, and the cost of that to the NHS, prevention is always cheaper than cure. I mean, I guess from your perspective, as a Gloucester resident with type 2 diabetes, why haven't I got a one-stop shop? Why haven't we taken that best practice and rolled it out across the country? What's stopping the Sheffield one-stop shop being in Gloucester, being in all of our constituencies?
We need to see the facts. I mean, we've piloted it, we've evaluated it. It is patient-friendly. The patients love it because they don't have to have 6 appointments. A lot of these people are disabled, unable, a lot of difficulties. It meets a sustainability agenda, and the nurses love it because they become good at something, really become. GPs love it because they get a report. The patients also get a record of their risk, and they become drivers of their own management. They don't need, give them an app. So it hasn't taken up because, like everything else, it takes a long time. But I think people are now waking up because of this. Prevention is now the agenda of the government, and hopefully it fits in with that. So it will target prevention, people adopting healthier lifestyle. And it can be done. With the medications we have nowadays, we can normalise every person with diabetes, which we didn't do before because it caused hypoglycemia. We didn't have the drugs. We have weight loss jabs now that target weight, exercise programs. In one of our studies called the Oceanic Trial, we've normalised every person with diabetes within just a few weeks. So we have the tools.
Yeah, I guess so. I know I'm conscious we've got NHSE and DHSE colleagues sat at the back. If you had one message to them about how can we get that model rolled out tomorrow, what would be the message to the people with the power to roll this out? What is stopping us? What would stop you tomorrow from rolling it out further across the country?
Absolutely nothing. I think that we have a system that works for eye screening, which is brilliant. Align it with that, which is what we did in Sheffield. The eye screening program is running. The patients are sent an appointment through the eye screening program. Everybody attends that, and but we warn them it's going to take a bit longer, and we have space. Already, many GP practices have plenty of space. Not all of them. We have the bigger hubs for PCNs, and it can be rolled out tomorrow. Of course, we need to look at the barriers. What are the barriers? Are the people that live in remote areas? The implementation science is required. The new science of implementing this is required and scaling it up. But I don't think there is any. We need a task force that looks at this and can be rolled out very quickly. It's cost effective. It will save money. It will de-stress the GPs that have too much to do, and it will really be a game changer in my opinion because the investment is very little. 10% is invested in foot care at the moment. The cost is we have massive expansion of foot clinics. We've got 12 foot clinics in Sheffield. Mm-hmm. So that's not a mark of success. That's a mark of failure. We need to take off the cost of expensive hospital care. It's just look at yourself or myself. If I have a healthier lifestyle and I don't get ill, I'm not going to cost the NHS a lot of money. I'm going to have a longer lifespan, and this can be done. And the evidence is there. We've done it in Sheffield, and I think it can be rolled out tomorrow.
Great, thank you. I'll hand back on that point.
Well, it hasn't.
Right. Good morning. My next question, I think it's a really interesting one. To what extent do you believe, one, media attention in these areas, pressure to ministers and MPs, how much influence do you think that had on these projects actually being launched in the first place? And has it just been used as a sticking plaster? And I'll start with yourself, Solomon.
I think that's a very good point. When we had APPG on diabetes visit, Tom Gordon came and Alex McIntyre also very kindly, honourable members, came to visit us. That's exactly what I said to them. Please drive this, because there's a new government and then another government comes. This shouldn't be a sort of a government agenda for one government. Appropriate funding needs to go, it's got to be independent of that, driven by all party and implemented. It needs investment. We shouldn't just have discussions and meetings. Action is required, and action is required now.
Thank you. And John?
I think the media plays an important part because the all-party parliamentary report, No One's Listening, identified that without the investment that Solomon talks about, without the investment in sickle cell, you will have more preventable deaths. And that was one of the reasons of the No One's Listening report. Why is it that for the country's biggest genetic blood disorder, we are still having preventable deaths in accident and emergency and in wards? And that was a real big drive. And of course, the press picked that up. So there is a role, and patients are very vocal about the fact that, why is our care so poor compared to other conditions? So I think it does play a role, and credit to the all-party parliamentary group under Pat McFadden and Janet David. They drove, as Solomon said, they drove this, and that resulted in the question that Ben Coleman raised about NHS England saying, actually, you make a good point, we need to do something about this. But the doing something about it is short term.
But before I go to Jennifer, do you not think the doing something about it was finding some money at the back of a drawer, shutting you up, putting you in a corner, and then doing nothing with it?
They can't shut us up, first of all. We're very vocal. We're very vocal, and we are clear that and it comes back to having a bigger plan, because you can't have these pilots, which clinicians and patients are saying are making a difference, and then say, well, no, we can't sustain it, we can't roll it out.
I've known you a while, and I'm going to beg to differ, because what they do is you get the money, you go away to do that piece of work, hoping that it will be rolled out, and while you're doing that work, it's out of the spotlight, as happened in Birmingham that you saw, and then things deteriorate and the money is removed. So I am going to beg to differ. I'm doing it for a reason. And yourself, Jennifer.
I think the HOPES funding came on the back of a very high-profile serious case review that was overseen by the Secretary of State. There were a number of pilots that started at that time. There was the ICTR programme, and Baroness Hollins was leading that. There was the senior interveners, and there was HOPES, which was the clinical aspect in terms of reducing long-term segregation. There had been a number of CQC reviews. As I say, Baroness Hollins had produced a report, and I think I think people set up the programme with a genuine want to kind of address the issue. I wouldn't say, I don't think it was just to get it out of the spotlight. I think people really saw the trauma and the human rights breaches that were happening. But I think then what happens, as you say, is that people kind of move on and actually the problem remains the same, and actually kind of the cultural change still needs to happen and the improvements still need to happen. And that's what we've been kind of struggling against now, because, in terms of moving this forward, we were kind of offered a webinar with other people. What we need is some action-orientated implementation, some infrastructure to do that.
So my final point is really, if there was a recommendation that you would like this committee to recommend to a way forward to the NHS to help scale up these pilots, what would that recommendation be? And I'm only looking for one recommendation. So I'm going to be awkward, Jennifer. I'm going to start with you, then I'm going to go to you, Solomon, then I'm going to go to my very good friend, John.
For HOPES personally, rather than any other pilot, because obviously they're all great pilots, but I think for HOPES personally, it it needs to continue to be nationally funded. I think it's a specialist programme that needs to be nationally funded until the kind of, for a few years until we get the cultural change across the system.
So you are clearly saying you do not want ICBs taking over the funding?
No.
Fantastic. And over to yourself, Solomon.
Thank you very much. I think we need to build on a great British success story, and that is the eye screening programme. Within 10 years, diabetes, which had been for 50 years the commonest cause of working age blindness, was completely demolished when we had a separate service eye screening programme where every person with diabetes had their eye screen. Earliest changes referred to an ophthalmologist, early treatment, game changer. That's what we need within 10 years. And if we adopt a community neighbourhood hubs aligned with eye screening, all the other health checks, early management, aiming at prevention, and this will be a game changer. It's the only country in the world where eye disease is not the commonest cause of working age blindness is Britain. Let's build on that. Let's have neighbourhood hubs doing one-stop shops, properly implementing, using state-of-the-art screening tools. Can be done. We've done it in Sheffield. It can be scaled up.
Thank you. And John, over to you.
For the sickle cell emergency care pilots, the solution must be found to have a plan that sustainably funds these pilots going forward, and that should be funded centrally. And the reason it should be funded centrally, not dissimilar to Jennifer, is that we know, and you raised the point yourself, Paulette, that with the integrated care boards, there is so much variation, there is so much chaos. It would be unacceptable to just add that to ICBs in the current climate to say you sort this out, ICBs, in terms of the funding. So that's the solution that ensures that these pilots are sustained and funded as part of a bigger sickle cell improvement programme.
Thank you. And on that note, I'll hand back to the chair.
Thank you very much. Well, even to say thank you so much, all of you. Your passion for your areas shines through this morning and gives us plenty to talk about with our second panel. Thank you. If the second panel could, as quickly as possible, please come up. Thank you again. Thank you. Fill your water, get yourselves ready. Lovely to meet you all, and thank you for your time. So as with our last panel, we are here to discuss NHS Pilots, and we have a slightly different perspective now. We've got representatives from the bodies who are here to deliver, commission these services. Can we start with, as before, quick introductions, perhaps starting with Claire Fuller?
Yeah, good morning, Claire Fuller. I'm the National Medical Director, GP by background, and have a past history of being a Chief Exec of the ICB in Surrey.
Very much.
Hi, I'm Professor Kath Checkland. I'm Professor of Health Policy and Primary Care at the University of Manchester. I'm not here representing NIHR, but I've sat on NIHR funding committees and been in receipt of NIHR funding, both as an evaluator and as Director of a Policy Research Unit. I'm therefore here, I think, because I've got a good understanding of NIHR evaluation infrastructure, and I was the lead external evaluator for the Vanguard programme. I just should say that my comments today do not represent the views of NIHR.
We are excited to therefore hear them. Yes, and finally.
Good morning. I'm Kath McLean. I currently chair 3 integrated care boards, Derby and Derbyshire, Nottingham and Nottinghamshire, and Lincolnshire, and my past includes being a clinician.
Thank you very much. Before we start, can I ask a very quick question of you, Claire? Much of the documentation that we've been looking around this talks about the innovation and adoption strategy, but we can't find it. Has it been published, and is there a timeline for that?
I will come back to you on that.
Yeah, because it seems to be, I mean, adoption, as you heard, is a big old theme, and
indeed.
we can't find this document, even though there's reference to it in all sorts of plans. So, that would be really helpful as soon as. We'll start with Andrew George, please.
Thank you, Leila. Dr. Fuller, perhaps I will continue with you. Obviously, the NHS is about to go through, or is going through, a process of very significant rearrangement. But how is innovation and continuous improvement currently managed within the system?
Yes, so I think it's really important. So we're talking about NHS Pilots, and
yes,
actually,
of course, yes, sorry.
But when we talk about NHS Pilots, I think we need to be really clear what our definition is, because I think when we talk about pilots, sometimes we need to remember that what we're talking about, and we had, I think, some brilliant examples in the first session around change that was initiated because of poor outcomes that were highlighted and need for change. Some of the most powerful innovations and powerful pilots that have been led from the NHS have been based on new innovation that have come out. So if you think about things like fit screening, you think about COVID vaccine, you think about COVID testing, those are things that were led nationally and spread really effectively out across the entire country. And so some things that we lead nationally and some things need to be led locally. In terms of how we do that currently, we have the NHS Impact Board, which actually leads learning networks around the country based on specific needs. And at the moment, one of the areas that is being closely worked on is the frailty collaborative, so working with 7 areas that are leading the way and making sure that the learning from those sites is then spread so that those 7 sites maximise their opportunities, but then also we take that learning and we spread it more closely. You've got the National Neighbourhood Health Implementation Programme, and I think my colleague earlier gave the most beautiful case for why neighbourhood health should happen in terms of diabetes and how we manage. But actually, at the moment, I think the way we manage innovation is through being really clear what the outcomes are, and then making sure we spread and learn from best practice as we go around the country.
So I mean that begs the question: is innovation better developed through central diktat, as it were? Do clinicians at the front line just operate too much within a straitjacket of what the centre is dictating, and doesn't have sufficient freedom to as you say, identify where problems are and to innovate at the front line rather than waiting for the centre to permit them to undertake a pilot?
I think we have to do both, don't we? So I think then that's at the heart of quality improvement, and that's at the heart of, as clinicians, we always want to deliver the best possible care we can for our patients, and we're constantly evolving and constantly changing how we deliver that care. So nationally, I think our job is to identify new technologies, identify innovation that we know will help, set the parameters, set the outcomes and monitor those outcomes, but actually to dictate in detail how every place and how every practice should deliver that won't work, because they're all so different.
Right.
We've got thousands of GP practices, we have got hundreds of trusts, and they're all different for very valid reasons. So I think we set the parameters, we identify the innovation, we identify the new technology. NICE 10 years ago was authorising 2 new drugs every month. We're now doing 2 new drugs every week. The pace of new things coming through is extraordinary.
So I mean, Kath, for example, I mean, you're closer to the front line. You're still somewhat distant from the front line. I mean, do you perceive that the environment is sufficiently enabling for innovation to happen without it having the okay from the centre?
Yes. So if I just take the opportunity to sort of just say a little bit about, you know, the overarching role of an integrated care board is to arrange health services for the population, and it needs to do that based on an understanding of this, you know, the health of that population, what its needs are. And I think, as Claire says, I think you need both. There are some things which have been proven to be effective and would be great to roll out everywhere, and I think to have a national indication to do that. Otherwise it's going to take ages for everybody to learn about it. But there's lots of things, and we've got some great examples across my patch where it's developed much more locally based on you know, the needs of the particular communities and populations, the clinical leadership that there is, the buy-in from the partners, quite often in changing the way that services are delivered. And the challenge there in this business of pilots is they suffer sometimes from the same challenges as others, is that there's a bit of money to begin with. But there are various things which I can go into at some point as to why it will be successful and lead to substantive funding later on. So I agree it's both and, I think, that we need.
Okay. I mean, can I just challenge you on one? For example, in 2010, I think it was, the NHS Confederation produced a report which was a form of innovation saying why we need fewer hospital beds. And that was kind of quietly rolled out since that time, and now we end up with corridor care and ambulances queued outside hospitals. I mean, it's not a great innovation.
So not all innovations end up working, but in that instance, you know, we've heard a little already about the potential for enablement care. So shifting to prevention, Solomon's really great description of diabetes and so on. If we can do those things, we'll end up with people you know, not needing to go to hospital as much. So I think that you have to look at it in the rounds and join up with social care and so on as well.
Of course. Dr. Fuller, so we're going through change. I mean, do you see the opportunity of the merger and the merger not only of NHS and NHS England and the department, but also the ICBs? There's quite a lot of turmoil going to be happening. Do you see that as an opportunity to promote innovation, or do you see that as a challenge?
I think the changes that we're going through bring greater clarity of purpose for what we're doing nationally and what we are doing across ICBs, across bigger geographies. And I think the clarification of the role of an ICB as a strategic commissioner is really important, because actually what you see in terms of the brilliant examples we had earlier on and the rollout of new innovation is actually really good basic commissioning. So I started my life running a CCG, and when CCGs were created, there was an awful lot of learning around what commissioning was and how to do it. And I think one of the things I'm really pleased to see is that as we move into ICBs becoming more strategic commissioners, actually that we will make sure that there is increased support to ICBs to make sure there is appropriate capacity and capability to do the things that we know that they do best. So it's a real return to this is about return to old-fashioned commissioning.
Right. So the NHS England's Innovation Ecosystem Programme report was sort of indicating that there's that innovation has been kind of stalled by concern about factors such as intellectual property, data sharing, barriers to collective effective collaboration between NHS and industry, and also the NHS Confederation have identified problems of duplication and a competitive environment which sort of stifles innovation. I mean, do you think that when you throw in reorganisation on top of that, is that not going to kind of create too many obstacles to?
I think the changes we're going through means that we will need to do fewer things better, which I think helps focus the mind. And I think the reliance upon innovation and actually on changes in technology will come to the fore.
Okay, and the innovation and adoption strategy, which
we'll come back to,
we'll come back to, which we need. So thank you. Yeah.
Thank you very much, Danny Beals.
Thank you very much. Claire, in terms of deciding which pilots or trials to prioritise, what's the kind of decision-making framework that NHS England uses?
I'll go back to what we mean by pilots. I think that influences how we make decisions and how we choose. So if you're talking about an innovation that's a quality improvement because we've highlighted that there is a poorer outcomes for the population, then it's very clear where you're going to go, and we've got the support programs that run, so things like the Getting It Right First Time program, things like the provider support program that will go into support providers actually improving their outcomes. So that would be nationally chosen based on poor outcomes. If you're looking at things like new technology that are coming through that we want to try, so I think I would go things like the fit testing, which has now allowed us to identify 600 more cases of colon cancer, and we started that in 8 sites where we had leadership capacity and willingness to want to work, and then because it was successful, rolls out, and we're actually now lowering the threshold, so we will find even more cancers at an earlier stage. Then when you look for the things like how we selected people to become part of the National Neighbourhood Health Implementation Programme, we had 141 applications from across the country, so 80% of the country applied to be part of that programme, and we selected 41 sites prioritising areas of health inequality, so because we know that the changes will have impact.
So I guess rolling back on my question, so those are examples of things you decided to prioritise.
Yeah.
I suppose my question was, why did you decide to prioritise those things to pilot or trial or whatever word you wish to use? But presumably there are many other innovations or options that people in the health and care system might want to see innovated or piloted. Why did you not choose them? Why did you choose the things you did? What is the decision-making framework that allows you at NHS England to decide what to prioritise for GIRFT or other programmes and what to not?
So that's between local and national decision making. So nationally, we were driven by national policy, so by a previous long-term plan and now by the 10-year health plan, and that's why hence the focus on GP access, on reducing non-elective admissions, on the neighbourhood health programme.
So you pilot the things because they're in the 10-year health plan. So is that the view then? Whatever is in the 10-year health plan has to be piloted. How does it then, I guess, get identified as something that should be in the 10-year health plan?
Okay, so the 10-year health plan was drawn up from looking at the evidence around best practice internationally, best practice around the country of what works and how we can do it better. So in part of the delivery of that, we need to work with local systems, local providers to actually make sure we're delivering that, but it needs to be based on outcomes. And one of the things we're doing as part of the 10-year health plan is the modern service frameworks, which are really important because they will give us the outcomes that we will then be able to make sure care is being delivered in the right way.
And so are you saying that from NHS England's perspective, unless it is identified as a priority in the 10-year health plan, it shouldn't be piloted or trialled?
No, because the other side of this is actually making sure we address poor outcomes, and that is looking at variation outcomes around the country and then actually stepping into support providers to make sure the constitutional standards are met. So if you look at things like so if you take things like the GIRFT programme, which I think has been one of our most successful rolls out in driving change, that started by looking at variation in delivery of orthopaedic outcomes. It now covers multiple surgical and medical pathways, but is driven by benchmarking and looking at current performance and then going in with clinical voices and clinical experts to actually work locally to bring about the change. So it has to be driven by new technology coming down through the pipeline and things that we can now do that we couldn't do previously, versus looking at the outcomes as to where places are not doing well, as well as looking at national policy, so things like the shift to neighbourhood health, the focus on prevention, the fact that we need to do more screening.
That's quite a kind of a very complex picture, isn't it? There's a lot of moving parts there, so it isn't just simply the 10-year plan. So is there a kind of overarching framework, I suppose, for all of those inputs? You know, new technologies, the 10-year plan, the other priorities, etc., programmatic input. Is there a kind of an overarching framework of decision making that guides kind of determining what should and shouldn't be piloted? Or is it? I think there's clinical priorities advisory group. Is that the key kind of input into decision making, or is it another kind of?
No, the clinical priority advisory group sits around the specialist commissioning piece of it. I think what happens is it's actually individual directorates that set their outcomes, set what we need to do for the year, and then we come together an executive team as a board to then bring the whole thing together in its entirety.
Is there any political input based in mind in the previous panel's discussions? Is there political direction about what should be piloted, or political kind of views about priorities or problems? Does that lead to kind of discussions about whether something should be piloted as a result?
I think media attention and political attention can shine the light on where poor practice is happening. But I think you have to come back to what are the acceptable outcomes, what is the best international and national evidence for how we should be delivering care, and that is what we need to make sure we're holding people to account for delivery of.
And looking at, so obviously that's kind of very nationally focused, looking at the kind of broader health system, which is kind of obviously a multitude of providers, local commissioners, ICBs, etc. Do you have a sense from the centre how many pilots are happening at various levels in the NHS of new or innovative practice?
No, I couldn't give you a number at all. I mean, if I go down to my actual practice, we would be trialling and doing things on a daily basis in a different way, from trying to improve the number of people that are accessing their prescriptions via the app rather than putting them in the box that sits outside, reducing people that are waiting in queues. So I think it's how you define pilots about being actually about quality improvement as well as the rollout of new technology and interventions.
There's no kind of central oversight of locally commissioned?
No, that would sit because it's happening within providers and sitting across ICBs as well.
And in terms of kind of budgeting for piloting, the 10-year health plan discussed, and perhaps colleague ICB Hatton might also have a view about this. The 10-year health plan discussed ICBs dedicating 3% of their budgets to invest in transformation, innovation. Is your sense that is happening? Is that achievable? Perhaps Claire, and then perhaps come to Kathy.
Yeah, it is not happening at the moment. It is definitely something that is aspirational. I think we have got more work to do, given the amount of change that is going on in stabilising ICBs, but that is something that we'll do in the future.
So I think it's variable is the answer. So I can give you an example from my Nottingham and Nottinghamshire ICB, in which we decided that prevention was really important, and we put aside, sounds a small amount, but it was 4.5 million in the first year of doing this, and then the second year we doubled that to align that to prevention and people to come forward with plans. And a really good example of how that's helped is we have a really, really effective severe multiple disadvantage. Start out as a pilot in Nottingham City. They did all the right things. They got the evaluations, the measurements, the partnership, the clinical leadership and everything all from the start. And then when the money looked as though it was running out, they were able to apply to that fund, and now they've got recurrent funding, and that can go on into the future. So I think there are some local examples based on the local needs. And as Claire said, nationally they couldn't possibly know all of the pilots because they are literally going on inside providers, inside general practice, across places and systems all of the time. And some of them are not successful. And if they're not successful, I think we refer to fail forward fast. So, move it off.
If things aren't successful, but no one's aware they've not been successful, is that not creating a system that continues to make the same mistakes in different ways?
Well, they are locally known about, and I think as ICBs have clustered together, they are covering much larger populations now. So there's a great advantage of being able to share across a bigger patch. And NHS Confederation does some work to try and do peer learning and sharing across the whole country.
Yeah. Kind of hearing that the 3% is not necessarily happening in many places, it's a kind of a patchwork. And do you think there's scope, potentially Claire or Kathy, scope for greater co-funding of pilots with industry or academic partners? Does it have to be NHS-led piloting?
Yeah, no, so I think the HINs, the Health Innovation Network, I think are doing some really exciting and really interesting models of driving change and driving innovation. I think Manchester is an excellent example of some things that are going on there. So I think we need to look more broadly at how we can do this.
That's a really helpful academic example. In terms of industry, so we've talked about new drugs and treatments, obviously innovations happening in, as you said, like new drugs are being approved all the time now by NIHR weekly rather than monthly. Is there any kind of view about whether, if industry has a kind of case to make about a new innovation or treatment, whether it should co-fund the piloting of it to demonstrate its value? Is that something that NHS England has explored?
It's something that we have looked closely at, yes. I mean, if you think of the rollout of the GLP-1, so the tirzepatide at the moment, so we are. It's really important because there are new medications that are coming out. We need to look at what the right appropriate support is for people as they go onto those medications. So we're looking at the wraparound services for that might be digital, might be face-to-face. But as an example of a pilot of a new medicine that's come out, we will then go on to make sure we nationally procure an offer that is then available to everybody locally should they choose to use it.
Nationally procuring, or kind of, so that would be the NHS buying it?
So in terms of the digital, so we've had great success with the digital weight management programme in terms of actually the support for people to be able to access. The GP refers in, and it's an offer that can then be accessed using a similar support for people on the GLP-1s, making sure actually that you're not just taking not just having the medication, you're actually getting the support to make sure your weight loss is sustained. We need to make sure there is a consistent national offer as part of a framework so that we avoid the postcode lottery of distribution.
Okay, thank you. And just finally, the Innovation Ecosystem Programme report recommended budgets for innovation which span multiple years, ideally spending review periods. Do you think that that's possible or realistic? To have budgets for piloting and innovation that go beyond 3 years, beyond spending review periods?
You know the power of the political cycle in terms of needing to have results within the spending review. Many of these changes are going to require much longer term investment, aren't they? So I think we need to explore all ways that we do it.
Thank you very much.
Thank you, Greg Stafford.
Thank you very much. And I'm always pleased to hear they're getting it right first. I knew you did that deliberately. But obviously that was a successful pilot because force of personality of Professor Tim Briggs and the forward-looking of the then Health Secretary Jeremy Hunt to get that. My point is not to make a political point, it's to simply say that in many cases, if not all cases, it's a lot down to personality and force of personality and local innovation. But the IEP report found that there was a lack of protected time and incentives for NHS staff to engage in innovation activities. So, Dr. McLean first, how do you build capacity at a local level to undertake innovation activity?
Yeah, I think it's a good question, isn't it? Because often people are very stretched and they're doing their day jobs and trying to find that. But there are ways of supporting people both within trusts, within primary care and across the system, so that actually there's a focus on those. One of the things is aligning it to the local strategy, whether that's within an organisation or elsewhere, and then it becomes part of the delivery arm. And very often we find that these things do well, as you've sort of indicated, where you've got clinical champions, people who really want to take this forward. And the honest truth is they find the time, and then they garner other people into the mix. And a lot of these things require a huge culture change. So that's an important part of that.
So just to push you on that then, so you sort of said, well, people find the time. Would you not think it would be better for you to somehow practically give them the time to do this?
Yes, so I think in good organisations where leaders spot what needs to happen, and I've been to visit many where this is happening, people are actually aligned to these programmes. The problem is that they're funded for short term for the programmes, and then it's what happens after that, and they need to be embedded. And this comes back a little bit to, have you made a return on your investment? So that measurement of that early on, and it's sometimes quite tricky, particularly if it involves multiple partners, that the benefits may be seen outside of the NHS, and I don't think we're great at acknowledging that.
So are you essentially saying that the IEP programme, the IEP report is wrong, or that you're not as concerned as they are about the ability at a local level for innovation?
Well, I think the innovation, it requires a certain amount of risk-taking, so you have to get partners agreed that they were happy to take risks. So if you're going to go innovate, you have to assume some of them might not work, and that's an important part of that. So I think there's much more for us to do, but I do think that within our strategies, and as has been mentioned, for example, strategic commissioning, I think will help us make some of these changes. But it's happening across providers at all levels as well.
Thank you. And Dr. Fuller, as Dr. McLean has just said, clinical leadership appears to be as crucial as to whether the pilots scale successfully. So how, from a NHSE perspective, have you been supporting leaders to give them those skills and, I suppose, the knowledge to drive innovation?
So one of the reasons I took this job rather than staying and being a chief exec of an ICB was actually realising the power and the need for clinical change rather than there is so much you can do with policy and there's so much you can do from executive land, but if clinicians do not start working in a different way, nothing actually happens. So one of the things since I've done in this job has been building a much stronger network of primary care colleagues around the country and actually better connecting primary and secondary care colleagues. So we produced the Red Tape Challenge document, and again working with the very fabulous Professor Tim Briggs. As a result, we'd both been around the country visiting some of the PCN test site pilots, and the things that they'd highlighted was actually the difficulty of communication between primary care and secondary care, and that actually the things that could have been done within a hospital setting were being passed on to primary care, increasing the workload. So we created a checklist for organisations to undertake, which they now do on a 6-monthly basis, looking at things like, are consultants making the onward referral, are we doing the fit notes in hospital as appropriate, are people, are we not, we're making sure that if tests are asked for in secondary care, that they're followed up in secondary care. So again, that's something that was a bit of a side product that came out from the visits to the PCN test pilots, but we've now spotted what are the things that will work and are then spreading, and then the bit that we don't often do is we often put the guidance out, but the bit that actually makes sure it happens is putting it into the national oversight and into the national assurance process.
I mean, I think that's an interesting example. I suppose on the wider point, I'm trying to get the idea of, do you believe that innovation in the NHS, certainly from an NHS England point of view, will only come and of necessity comes from individuals, whether they be managers or clinicians or both, driving this forward? Or is there a failure in the system that needs to be addressed? Or are you just comfortable, as perhaps, maybe I'm putting words into Dr. McLean's mouth, that people will find the time, the innovators who want to innovate will do it? Or is there something more fundamental that the NHS, either at a local or national level, needs to change in order to promote innovation? I'll come back to Dr. McLean.
Yes, so innovation is always it's the classic bell curve, isn't it? You're always going to get your 20% that are out and are leading the pack, and you want to make sure you never stop them, because otherwise you don't ever drive the change. The bit that we have to, and I think is the thing we're doing through the National Neighbourhood Health Implementation Programme, is identifying those themes and those trends that those trailblazers set, and then codifying to make it easier for others to follow. So we've got the 41 test site pilots with baseline now to look at what they're all doing, and a number of themes have come through that we will now baseline the rest of the country to look at where they're doing, and then we can then look to assist them. But I think you will never stop our absolute brilliant leaders that will always innovate, but what you have to do is then, for those that are working under more difficult circumstances or different have different skill sets, is to really codify and put into national planning and to put into national oversight and assurance to make it much easier to then drive up and actually bring the change across the country.
Yes, so I agree with that. You will always have people who are very keen to innovate. They come up with ideas, they send them to me even at times. But I think that some of the things that make small things become successful are aligning the incentives as well, so that actually there is both financial and other kinds of incentives get aligned. that you do link it to either national policy or local strategy, and that you can sustain that in that way. And I think developing leaders so that they know how to create the culture for it is also something that's really, really important.
So my sort of takeaways from this conversation then is that the key things are incentives and the freedom to take the risk within the framework of the strategy. Is that a précis of what you're both saying? Just so I could, I suppose we're not necessarily going to make recommendations, but if we make recommendations off this report, those would be the things that you think would be the key things to drive innovation.
Yes,
freedom
and
to take risk,
freedom to take risk,
and the incentive to be able
incentives,
to
the alignment to policy, a good approach to evaluation so that it starts early on, if it's not something that's already known to be effective.
Very quickly.
Data, you've got to look at the data, and you can't necessarily predict what it's going to show you. So I think it's a relentless focus on data. I'd put as your third one.
Thank you very much.
This is very neatly on to Dr. Becky Cooper's questions, I believe.
Thank you, Chair. Yes, thank you. So I'd like to discuss evaluation with you. So I heard you tell my colleague earlier that, understandably, you don't know how many pilots are running at any one time. That makes sense. But I wonder, Kath, perhaps with your NIHR hat on, if you know how many pilots, NHS Pilots, as defined by Claire, are currently being evaluated by the NIHR.
I don't. I'm sure that that's something that could be found out. I think HSNDR, the Health Services and Delivery Research Programme, does a lot of these evaluations, and I'm sure they have the figures. I don't.
Let us know, that would be great. And similarly, Kathy, do you know across your 3 ICBs, which is ambitious for you, do you know across your 3 ICBs roughly how many pilots are running at any one time?
Well, I don't know all the small ones, obviously. I am aware of some of the larger things.
Okay. So in the larger ones, how many have you got running across the 3 ICBs?
I think we've probably got, at the moment, about 4 or 5 larger ones that I'm aware of. But, I'm only a chair.
Okay, thank you. No, that's helpful, thank you. So, when we're thinking about evaluation, I think, as you rightly said, Kathy, the key obviously is to sort of plan your evaluation rigorously before you even start your pilot. But before we come to sort of the nuts and bolts of it, I don't know if there's a question for Claire, but I'm quite interested in the idea that evaluation leads to either a scale up or a close down of an innovation or a pilot. And I wonder, Claire, if you have any evidence of how many larger pilots have actually either been scaled up or have closed due to effective evaluation, and take a 3-year time period or a 5-year time period, whatever.
Yeah, I'm not going to be able to give you exact numbers, but I can, I've got a number of, I can give some real high. It's a Martha's Rule. I think that's a brilliant example of something that we piloted and we saw the impact from it, and then we scaled up. I think the one that is harder to give examples of are the things that we have stopped.
And always, Claire.
But I have one. I have one.
Okay, go. Yeah, let's hear it. Absolutely.
So I think the evidence for hypertension case finding is irrefutable, and I think as we come through the modern service framework, looking at particularly for cardiovascular outcomes, what we do, I think that's the thing that we'll find. One of the things we believed, and I think I personally believed this as well, it was that actually investing in more people looking for hypertension cases, so we looked at dentists, in different settings within primary care, that actually that was a good cost-effective way to find new cases of hypertension. Actually, when you look at the return on investment, there are better ways to invest your money to find more cases. So we are in the process of publishing that as a, look, we tried this, it didn't work.
It didn't work.
But we find it much harder to stop things, partly because so many things are driven by such brilliant clinical passion.
No, absolutely. And just before I move on, would you say it's reasonable, therefore, to presume that within excellent clinical practice at any one time, there will be ongoing pilots that perhaps aren't proving effective or sufficient ROI, but they continue nevertheless because stopping things is quite difficult? Would you say that's reasonable, Kathy?
It's a bit difficult to comment on that, to be honest.
Your experience as ICB chairs or a clinician?
Actually, I do think that if things are just not going anywhere, they do tend to sort of fizzle out, to be honest.
Okay, and that's interesting, your phrasing. So it's fizzle out rather than actually proactive, we are going to stop this decision.
One of the challenges is that for a lot of these things, so for example, if we do a lot of work that is looking at health inequalities, the gaps in survival for people in poverty-stricken areas compared with others, for example, and the time taken to see whether it's effective is long. So when do you stop? When do you actively stop?
And as a public health consultant, Kathy, I'd say you never stop that.
You never stop. No,
I'm going to move on.
Exactly, yeah.
So if I look at your pilot planning, so Kathy, perhaps I could come to you, because obviously with our NIHR skills, how well do you think evaluation skills are understood when pilots are planned, in your experience, and how available is skill training for evaluation, because it is a specific skill for sure.
Understood by whom, I think it would be the question. So we have a brilliant community of evaluation experts across the country. I think we're very lucky. We have NIHR. Many other countries don't have anything similar. And NIHR has invested very significantly in building an infrastructure of rapid evaluation. So we have a number of rapid evaluation teams across the country.
You have enough?
We'd always like more money in NIHR. I think that's fair to say. But the capacity for rapid evaluation has been extended quite significantly, particularly in the HS&DR programme.
And when you say rapid evaluation, Kathy, are we talking real-time evaluation? Are we literally saying we are evaluating as we go, and therefore we don't have to effectively start evaluation once we've undertaken 12 months of a project?
So I think that's very difficult because, as Kathy said, sometimes the outcomes aren't obvious for quite a long time. So sometimes you might start doing something now and actually you can't expect to see any change for 3 or 4 years. And that's actually very difficult in NHS funding terms anyway. So I think that we're certainly very good at we've got the infrastructure to get evaluation up and running quickly. Okay. We have the skills, and those skills can be transmitted as well. So we have the health innovation network across the country, what used to be the academic health science centres, the ARCs, which the applied research collaborations. We've done evaluation training locally. So in Manchester, we've trained the local
which
clinicians.
Which is wonderful in Manchester. I'm delighted to hear it. I suppose my follow-on question to that, Claire, is this standardised? I mean, that's excellent practice. Is this standardised across the country? So could I go to all 3 of Kathy's ICBs, my ICB, your former ICB, ICBs around the place, and see evidence of this evaluation training and skill set at work?
There will be variation.
Right. So that is problematic for us. Okay. And how do you propose to address that variation?
The best way to address variation, isn't it, is the way that you always do it, is you identify best practice, you benchmark, and then you shine a light, and particularly you. And people never like being a poor performer.
No, but do you have plans to do that, or is that something that you already do?
I will come back to you on that.
Okay, all right, thank you very much. And rapid evaluations, back to you, Kathy, are they the best type of evaluations to do in the National Health Service as it stands today? Is that the best way to essentially understand the pilots as they are working? I appreciate that there are longer term issues, I absolutely appreciate that, but in general, are they the best way to do it?
I think it depends what it is you're doing. I think for some of the very small pilots, then I think local test and learn, good data analytics support, quality improvement methods are the most. But when you're looking at something quite large, or which might involve a significant change in practice, then you've got to have robust evaluation, because as well as I do, regression to the mean means that something may look as if it's working, but then when you evaluate it properly, you find it's not. Absolutely. And there are many examples of those, and that's why I think evaluation is vital. So
my final question is longer term evaluation. We've established that you've got your rapid evaluation teams, you've increased it. Claire's going to go away and look at that sort of standardisation across the piece. The longer term evaluations, how are we in terms of resourcing that and allowing skills to be manifest across the country?
So again, I think we're quite good at that. So sometimes for some programmes, NIHR will go out to tender and they will procure a really all singing, all dancing evaluation. a long-term evaluation. What we're not very good at, I think it's fair to say, is necessarily waiting for the outcomes of those evaluations.
No, so, I mean, that's what I'm trying to get to. Like, in terms of, you can do an evaluation, but what does it show? Do you have examples of evaluations that actually the results were inconclusive, or you needed more time and you simply didn't get it?
I wouldn't say that the results are inconclusive. I think what we have a tendency to do is to go ahead and roll things out before we've got the full results. So there was a really good example with the social care and personal budgets. There was an evaluation, and actually the decision to roll out was made before the evaluation was finished. And I think we're much more likely to do that than for the evaluation to run out of money.
Okay, thank you. That's really helpful. Thanks so much.
Thank you. Quick question, Ben Coleman.
Yes, have you got examples, which perhaps you could write to us with them, of pilots which stopped, were then evaluated, and then were rolled out, and then started again?
Oh, I don't know. I'll find out. I don't know. Given that we've got so few pilots that have been stopped. Oh, so in terms of with the pilot
you're about to
bit
stop.
finished.
You're about to stop the sickle cell pilot, and my question is there an example of where pilot's been stopped because the money's been not made available, then the evaluation comes in, and then you start it again, which could be helpful in the sickle cell case? Or is it just, once it stops, even if the evaluation comes later, that's the end of it?
No, so because I think you have to come back to that we continue to look long-term at outcomes. And many of the cases that we're describing as pilots are actually quality improvement programs to improve outcomes. So that piece of work will be continuously ongoing. And actually the intervention that will bring about the improvement may change with time. So
evaluation shows that the pilot was effective and the pilot has stopped. Might you then still roll it out?
It depends how you're judging the effectiveness of the pilot. So I think the sickle cell one is a brilliant example because we've got you're receiving analgesia within 30 minutes. So we'll continue to look at that and see what happens. I think we have to finish the evaluation, and there is more work going on around, again, GERFTA looking at sickle cell services. But yeah, but I think it's coming back to, you can't, the world moves on. The pilot is conducted in a context, which is why it's really important at looking at the outcomes for the population as much as looking at the intervention that is going on.
Can I just ask if I've got this understand? So in its current form, with the staff that are there, and we got given the example of a clinician who's now worried for her job, and that's not great for productivity and the mental health and all the rest of it. In its current form, it may shut down, but there will be elements from within it that will then get carried over into the rest of the system, and that's the bit you're interested in. Have I understood that correctly?
So I'm not going to comment on it because we're awaiting the evaluation and no decisions have been made.
Okay,
however,
not that one, but as an example.
No, exactly. But the way we deliver services changes all the time, and that is quality improvement, that is continuous improvement, and you would want that to happen.
We are interested in that team, what they're doing now with that population in that locality. Not sickle cell. It could be any. We've seen it in community mental health hubs, for example. This is a common story. A team comes together around a passionate clinician. They then offer something to a community that says, hallelujah, we have an answer, and then it just fizzles out, disappears, never is seen again, and it then often doesn't get rolled out. So, I mean, this is one example of so many. So am I to understand that the fizzling out is kind of part of the process? You see that as okay, so long as elements from within that learning get rolled out? Or as my colleague was suggesting, if that does fizzle out, and then the evaluation comes back and says, actually, that was great, is there any chance it could be restarted?
It's the difference between implementing a specific project versus actually the concept of quality improvement. So at the basis of delivering clinical care, we constantly change how we deliver them because new things come through. So I would never want a service. So when I started in general practice, Ramipril, an ACE inhibitor, we had to admit people to hospital overnight because that was what we did at that time. Now I would start multiple drugs in the setting of general practice because that is the right thing to do. Medicine and technology continues to evolve.
I'm talking really up here, and I'm talking something very, very specific, which is those teams, pilots across the country, there are several of them, some in this room, some not. Those teams, if their funding isn't continued, specifically to answer my colleague's question, it is unlikely that they will restart in that exact form. Is that correct?
I couldn't guarantee that that pilot would remain in that form. I would expect that all clinical care would continue to evolve and improve.
Okay, I think that's as much of an answer as I'm probably going to get. Josh Fenton-Glynn.
Okay, I'm going to kind of carry on this theme. We regularly have the Secretary of State here. He loves the phrase, in the NHS, we learn from the best and roll it out to the rest, because he likes a rhyming couplet. I'm not sure it's true, though. Do we get the right balance between funding pilots and funding adoption? This is for Claire.
I know. So, I don't know, I think, is the right answer to that one, because I think I think it's very hard to view them as two separate things. So if you look at how the civil service defines pilots, actually they look at testing at policy, testing with the market, test and learn, and actually pilots then is the definition that we then use just for that bit actually of the rollout bit, which is why I know I keep coming back to it, but it comes back to the NHS definition of pilots isn't the most helpful thing, because we are covering quality improvement, implementation of new technology, and pathway change, whether that be local or national. So I'm hesitating to answer, because I think if you want the broader definition of pilots, actually implementation would be part of that.
So you think implementation is part of a pilot? A pilot scheme has an implementation plan attached?
So I think it's because we're confusing.
I mean, like broader rollout, not just.
But sometimes when we talk about a pilot, we are talking about testing a policy.
Yeah.
And actually, that's not the same thing as implementation.
Mm-hmm.
Okay, so just thinking of an example that we've seen, so they referred to the community mental health. As far as I can tell, it took them, I think it was a 3-year pilot, probably took them most of the first year to get up to speed. Then they have maybe a year of operating, and then they're sort of winding down and evaluating for the 3rd year. It doesn't feel like an effective way, particularly when something's working, for the NHS to be rolling something out. It doesn't feel like that's the best way to get the results, the best way to get the understanding, and the best way to hopefully push it out.
I think our most effective way to drive continuous change is through quality improvement, rather than necessarily a right. I mean, it's.
So I guess the problem then is that you're not doing anything radically different, because you're just improving processes in places. But if the model's not working, so mental health being a good example, then you're not actually changing things on the basis of kind of.
Look at some of the things that we have changed radically. So if you think about things like the rollout of the COVID vaccine, COVID testing, I think fit testing is a brilliant example of that. So radical change will come with new technology and new innovation. When it is improving how services that people that we know we need to look after against a thing, and we have agreed outcomes, and that's the importance of the modern service frameworks, making sure we've set those, then that is about quality improvement. But it is helpful to test the policy in isolation to make sure that it works, and then spread that.
It's interesting you mentioned COVID vaccine, because that wasn't done as a pilot. B, actually, one of the things that worked really well there was a clear need, and then they rolled it out. And frankly, they skipped. And I was a council cabinet member for social care at the time, so I was kind of saw that roll out firsthand. It seemed to me very clear that actually one of the things that they did very well was remove some of the normal bureaucracy, and perhaps that's something that we actually do need to learn from. You're nodding, so I'm taking that as a sense that we're going to do it. What tools are available to successful pilot projects that we're looking to scale?
So there's a national offer, and there will be local offers as well. But nationally, the improvement team put together learning and innovation networks that are led from local leaders that are doing well. So the Frailty Collaborative is a really good example of that. So you're bringing together those that are really high-performing places, they spread their learning and then they share it. We're doing the similar with the National Neighbourhood Implementation Programme. It's communities of practice, it is the sharing of the evidence, and then actually the opportunity for frontline leaders to actually make sure they've got access to the right resources to help them unblock the problems that they come up against.
But what's your reaction to an experience of people like Dr. Kilcoyne in the first panel who said that they don't have the tools and support to scale up their project better?
So I'm very happy to have a conversation about what we do, but I think that is about local variation, and it is understanding how we can better support people locally.
So moving to local variation, Kathy, McLean, one of the stated aims of the government is to use the NHS as an engine for growth. Part of that is having successful pilots and so forth. What efforts are ICBs making to be better recipients of that innovation?
So I think, as has already been said, ICBs are moving to becoming strategic commissioners. So that, in essence, means we will be more effective in terms of the commissioning cycle. We will understand better using data what the local population needs, and then tailor that based on communities to what is actually commissioned, and the outcomes will be much more. We keep saying outcomes, but it is something that we haven't focused on in the past, and so we'll be seeking those outcomes, and that will quite often require innovation.
Can you define the key outcomes? Obviously, patient outcomes, i.e. healthy life or comfortable life. What are the other outcomes you're looking at?
Oh, well, they're myriad. We've got an outcomes framework, and that links to there's some high-level things, but there's also some very detailed things in there for each of the programmes. And I mean, just kind of going back to this, what makes it successful? Why don't things work? I mean, one of the examples I would give that I think is working pretty well is the targeted lung health checks. National programme, we piloted it, and I was so interested in it. I went to visit it, I kept a track of what was happening, and I can see that it's rolling out across the country, but not equally everywhere. But I think that's one of the reasons that's doing that well, is that it clearly met a need, and that's one of our jobs to do, is ensure we meet the need, and particularly in deprived areas, and therefore we arrange buses to go to those with the kit, you know, so that you really get into that. So I think we will be driving innovation, because I don't think we have an alternative, really.
Is it the case? So one of my previous roles is at the GMC, looking at medical education. There is often a vast difference between trusts, and often the trusts in urban areas, better funded, often better heeled areas, would be more likely to be centres of innovation. Is it the case that actually we spend a lot of time innovating on the already healthiest patients?
Ooh, that's an interesting one. So I think there's a difference between a trust, and then our job in ICBs is to understand the population whole health and be able to break that down, and we can do that to varying degrees. We're able to do that really, really well. But I think it is fair to say that if you look at, for example, elective care, more people who are from better off at the higher levels of that tend to get more of the elective care, whereas those from the deprived areas tend to use our emergency services far more, and probably not accessing as much as they should on early cancer diagnosis and elective operations and so on. So I think there is a distinct variation, and one of our jobs will be to think, how do we use our resources and apply it to...
Kath, trying to get Go
ahead. No, so just something to say on that I think we know that treatments tend to get tested in better off populations, and one of the things that NIHR is trying to do very much is, and this is something which every project that comes through to the funding committees is asked to ensure that they are looking at how they're going to recruit from the more deprived populations, and that's something that I think the NHS is putting a huge amount of focus on, is how do we make sure that we're we're not just going to the usual populations where it's easy. We're saying, actually, no, these rural and coastal communities with deprivation, why are we not recruiting to trials, for example, from that? So that's something that's a big focus for NIHR.
I guess, in some ways, the advantage that the NHS has over so many health systems is an access to a wide variety of patients. We see that with some of the stuff that's in the cancer plan today. But at the moment, as things stand, I'm not sure that people feel fully confident that pilots will always have access to those patients. How are we going to make sure that happens, Dr. Fuller?
So I think you bring in another really interesting angle of the importance of research, again, and whether we're describing research as being pilots, but again, which is the importance of why we evaluate it properly, and teaching hospitals and the importance of research to the clinicians within them, I think, is the thing that we underestimate in terms of what keeps clinicians engaged and keeps clinicians involved in their jobs. We need to do more research in other settings, in particular in primary care. And actually, as we have more large-scale primary care organisations, actually there's some brilliant examples. So Vishwaratnasuri in Birmingham looks after a population of several 100,000 and actually runs research across those, including some really quite deprived areas. So it's getting better, but it needs to get better.
Taking the mickey with my time, I'll hand back to the chair.
Thank you very much. So, Kath, you've had a long career in this, and we've got a 10-year plan. We're looking to do things differently. Huge reorganisation of the NHS, big changes, well, arguably a return to the more strategic commissioning of the past. But you were a key evaluator of the Vanguards programme, and there are key lessons that we all need to learn from this. Lay it to us straight. What are the things that if we don't do better, we are going to fail, from your experience of particularly the Vanguards programmes, but indeed your entire career?
I think what I've spent a lot of my career doing is evaluating these really complex pilot programmes, such as the Vanguards, which are very different than, say, a service evaluation, such as, say, the Sickle Cell, which is really focused. Vanguards was huge, and there were multiple objectives, and I think that's one of the things. And I think I would say that about the neighbourhood health implementation programme, which my team are in part looking at the moment, is we need to be really clear what it is we're trying to achieve. And I don't think we're quite there yet, and I think there's more guidance to come, and there's more, but we need to think about, one of the things that happened with the Vanguards was they started off with a very broad remit that was all about integration and people could set their own objectives, and then in year 2 of the programme they were suddenly told, oh, if you're not reducing emergency admissions, we're going to cut your funding. And a lot of them hadn't started off trying to. So I think we need to be really clear from the beginning what we want people to achieve, what our theory of change is, what our logic is, why do we think this thing is going to deliver what we want. And then the other is, I think, for something very large scale, like neighbourhood health, certainly what we learned from the Vanguards is we did some longer term evaluation. We looked at outcomes after 3, 4, 5 years after the programme had ended. And we found that in some areas, outcomes continued to improve. And so I think we need to be really, my big plea would be, let's not make any changes again soon. So let's do this, and let's put money in it, and let's put energy in it, but then let's stick at it, because for something as complex as neighbourhood health, it's got lots of moving parts. We're moving things out into the community, lots of different ways that we're going to be doing things. We're not going to see any benefits in the short term, probably. The benefits are going to come longer term, and so we need to stick with it, but we need to evaluate it properly.
What time frame would you say to politicians? Hold fire.
Oh,
forget about the spending review for now. Of course, we the department won't. But from an evaluation perspective, from a rollout and implementation perspective, what is the right time frame?
So I think that it's going to be five or more years before you really see benefits. That's not to say that I think we should let the 40 sites. We've got to move more quickly than that, but we need to really spend our time now with those 40 sites, defining what it is we're trying to do. We don't quite yet know what it is we're trying to do. And I think we need to define that now and then build evaluation around that.
When you said we aren't quite there yet with what it is that we want to do and something's coming, what's coming that we should be expecting?
There's more guidance.
There is more guidance. So I think we are more clear. So that we know the things that neighbourhood health needs to fix are GP access. We do need to reduce non-elective admissions. We do need to have an impact on the waiting lists. And so what we're doing at the moment is we're baseline to see where people currently are. We've done the 41 test sites at the moment, and we'll do the rest of the country, which will then start to give us a bit more of a roadmap about when you might be able to expect to see some progress around the country from this.
I think what we're not quite clear of yet is exactly what neighbourhood health is going to involve. We know what the problems are, we're not quite sure what the steps are going to be.
And have we set out interim evaluations along the way? I mean, how are we going to be able to hold department to account for the direction of travel? So yes. Okay, and that's all to come, all the detail of that.
All to come.
So when can we expect some of this detail?
We're hoping that the model neighbourhood guidance will be out in February. And then there'll be more information about the model neighbourhood health centres, and then of course we'll have the we'll have the workforce plan that will include a chapter around neighbourhood workforce as well.
Right, and then interim evaluations.
Well, we will continue to monitor. So the things we will be looking at will be we just need to agree the metrics around GP access, around non-electives, but also around patient experience, around staff experience, and the proms and prems as well.
And there is formal evaluation going on. So the strategy unit from the Midlands are doing some work with the implementation, with the pioneers, and I can't think what we're calling them, the implementation pilots. The strategy unit are working with them particularly around data and monitoring. And then one of the NIHR rapid evaluation units in Northumbria have been commissioned to do a more formal evaluation of neighbourhood health, which they're working on, and they're getting up and running at the moment. But that's going to be a longer term evaluation that's going to look particularly at implementation and the factors affecting implementation, so that we can make sure, because one of the things I think with all of these things is that when you're talking about complex service change in a complex environment, there's lots of issues around implementation, which local contextual factors which we need to understand. And I think evaluation is going to be very important in making sure we understand what supports things working and what gets in the way.
From an ICB perspective, does this sound good to you?
Yes, I mean, in fairness,
what you need?
yes, I've got one of those pilots on my patch. But that isn't stopping us going ahead with developing neighbourhood health, because if we wait for the 5 years, we just can't. So we are getting on with that, looking for the guidance and so on. But again, I think that it will be implemented I think it will be very different in different places. As you mentioned, the coastal, I've got a bit of coast. It's going to be really different out on the coast of Lincolnshire compared with in the Peak District or in the centre of Derby. So we are doing that. We will learn as we go along, and we will look to the outcomes as set out in the guidance when it comes.
I have one final question / thought. Obviously, pilots are inextricably linked to innovation and improvement, and I think, Claire, you've taken pains to make us understand that in its context. But we also heard quite vividly from the last panel, and particularly from my Deputy Chair Paulette Hamilton, who really drove this point, that so often they're set up when there's intense media scrutiny, when a prominent MP or a effective APPG takes this on and it's got political heft behind it. And it happens, and that community is really delighted that it's happened in the places where the pilot runs, and then they sort of go away. I suppose my reflection is, and I'd love your comments, are there just too many pilots? Claire?
The joy of the NHS, isn't it, is that we're the 7th biggest employer in the world. We have got an ever-changing landscape of brilliant new innovation that is coming through. There will always be people that want to do new things, and we should celebrate that people want to continue to making care better. Again, I'll come back to it. Depends on what we mean by pilots.
No, I understand. But let's just take the three examples. Yeah. Even community. So something that's sort of a specialism, an interest area, and they set up in a particular community. And I suppose the bit I'm trying to get to here really is, are we not just leading people up to the top of the mountain and showing them what's possible, and providing very often a level of hope, especially to families and patients, that this could be not just better for them, but also better for so many others like them. But actually what we're doing is we're just helping politicians say that they had a sort of a win. And for a little while, someone was looking at it, and then forevermore someone can say, but we looked at it, we did a pilot. But actually it's not really address it. The better thing to do would be to not do a pilot, but instead do something that's more long-lasting and improvement in that area. I'm not suggesting we don't stop improvement in that particular area. I'm just perhaps suggesting that those specific 2-3 year pilots in specific areas like that, are they just not a bit cruel?
I think our role nationally is to set what are the really important outcomes and hold people to account for them. Nationally, where people are achieving that, that's absolutely fine. You will get local variation because of different demography, different geography, that means that you do need to deliver care in different ways in different places. And I think something like sickle cell is a brilliant example of that, in that there will be different concerns of different issues around the country. I think the political insight and shining the light on the fact that people were not receiving analgesia within 30 minutes has been incredibly helpful. And that is not going to go away. We need to keep on improving. I feel like we do just need to keep on improving how we deliver care and striving to deliver better outcomes. Sometimes that will include enabling people to have a small amount of money to test different ways of working, but ultimately that then needs to become how we deliver the care. We need to stop relying on pots of money.
You're saying even if it is a bit cruel, it's still worth doing.
I think it is still. I don't think it is cool, because I think it shows you how you can do things, and actually what the bit we need to get better at is making that how we deliver the care rather than making it additionality.
Yeah. And Kathy, from an ICB perspective, it's going to be ICBs that are often asked at the end of these evaluations, and every single one of them shows you save money. It could be 200,000, it could be millions, whatever it is. But what is the one thing, and I'm going to press you just for one, that needs to change so that ICBs in their new roles will feel properly empowered to roll out these great ideas in their communities, rather than just, well, lucky them, they've got a pilot, but what about us?
If you want one thing, yes, I think it's some of this is certainty of resource, so that we can assign it to things and know that it is going to go on. I think I think that's quite an important
When you
one.
say, I'm going to press you on, no, it's going to go on.
Yeah.
What does that mean? 2, 3, 5, 10. Give me a horizon here. What does that mean?
Well, if something's going to work well, it could go on for years, and it should go on for years and years. You want it embedded in the normal, the business as usual, the doing things as normal. I mean, the tricky thing, because you've asked me for one thing, is you need to know it's going to work, first of all. So you do need to know it's going to be effective. But once you've done that, and this comes back to measuring from the start, knowing what your outcomes are, objectives, alignment, etc. But then you can employ people and give them longevity. You can even then, I think it's easier then to spread, because you've got people who can then share that across. But if you've got bits of money, pockets of money, which we've had, and Patricia Hewitt's review referred to this as well, pockets of money coming, it's okay for a bit, but you can't get that longevity, you can't get that ongoing improvement. So that's
better
really
pool the money for improvement more over a longer period, rather than have pockets of money that then just suddenly disappear.
Which is what we've done.
Okay,
we did
clear.
Nottingham, we did this Health Innovation Fund, and people could bid against it to do small things, some of which will go on because they're successful, some won't. But not everybody's been able to do that. And it sounds like a small amount of money, and it is a relatively small amount of money, but in the context of our large commissioning amount, it is quite small, but it's really valuable.
We're about to lose quorum, and I'm going to give the last thought to Kath. Go.
Well, I was just going to say that I think some of it as well is that it's very different for different types of pilots. So, for example, if you think about the diabetes example, which is clearly working very well in Sheffield, where I was a GP in the Derbyshire Dales, it wouldn't have worked for us because the people don't want to travel to a hub. They don't. It would be it's very, very different. So I think that it depends on the thing that you're dealing with. The context is really, really important. And so I think there are some things which you would clearly say. So, for example, the standard around analgesia for people, that's really important. How you deliver that, you might deliver it in different ways in different places. And I think we need to be aware of the contextual differences.
Thank you very much. Really appreciate your time.